Right. So we're going to go on with the talks, and we're going to now talk about the two aspects, or at least the one aspect that was there in the definition that we had enunciated earlier, which was the impact of hyperosmolarity. So what happens? Is there really any hyperosmolarity? And is there a role of trying to protect us from this hyperosmolarity, which is what we call osmoprotection? I don't have any financial disclosures here. So as we all know, that the vicious circle of dry eye disease has tear film instability, hyperosmolarity, inflammation, and apoptosis as the key events that perpetuate this cycle. There are various extraneous factors that impact this, which are all enunciated in this. This chart is now a familiar chart that we all see, with hyperosmolarity being one of the key which initiate the whole process. So the osmolarity of the normal tear film is between 296 and 302 milliosmoles. But in dry eye disease, this value is generally much higher at about 316 to 360 milliosmoles. It is estimated that over the central cornea, this may be much higher because there's a very, very thin tear film in that area, but that's not where the samples can be collected in clinical practice. So osmolarity is important because when the proportion of water to the solutes in both the tear film and in the cell are the same, the system is said to be in an isotonic state. But when there is evaporation and there is a hypertonic environment, the cells lose water, and this causes them to shrink as they become dehydrated. But as you understand, a tissue cannot really shrink. So it has to retain its own volume. And so the cell undergoes what we call regulatory volume adjustment. And it does this by introducing or imbibing salts. And along with the salts come in the water, which restores the volume. However, the salts are metabolically active, and they decrease the cell function and cause stress activation, which then leads to cell damage and cell death. This ocular surface damage starts fairly early in the whole process. And on day one, there can be dry eye and hyperosmolar stress, with stress kinase activation and transcriptional activation leading to acute epithelial disease. And by the end of the week, we enter into phase 3, wherein we now get a chronic ocular surface damage because of the influx of the cell-mediated inflammation or the T cell cytokine release. So this is the timelines on it. So what happens? Can we actually reverse this whole process against hyperosmolarity? Can there be some other compensatory mechanism? Yes, there can be. And we can offer these cells of the corneal and conjunctival epithelium the option to use or employ or import compatible solutes, which leads to a regulatory volume increase because it comes coupled with water, and the restoration of the cell volume happens. But these osmoprotectants or compatible solutes, which are taken up by the cells, do not interfere in the cell metabolism. They will restore cell volume and stabilize protein function without any negative effects. So these compatible solutes are small non-ionic organic compounds that build intracellular osmotic strength without damaging proteins. And osmoprotection is the process by which the cell functions without this damage. Numerous tissues in the body have this capacity or capability to either synthesize or import these compatible solutes, but not so lucky is the corneal epithelium. So let's look at a couple of lab studies and seeing the effect of the compatible solutes on hyperosmolar stress in corneal epithelial cells. So human corneal epithelial cells, which show the phosphorylation ratios to the total amount of MAP kinases as a result of hyperosmolarity, are substantially protected when the media introduces L-Carnitine and erythritol, which are the osmoprotectants. Similarly, clinically, there is a superiority of osmotically regulated tear preparations over passive tear substitutes. And if we look at desiccated corneal epithelium, we find that the rehydration of the epithelium occurs very nicely in the cells which have been exposed to an osmotically regulated tear preparation. If we look at osmoprotectants and their impact on mRNA expression and protein production enzymatic activity in cells or human corneal cells which are exposed to high osmolarity, one can see that as the osmolarity goes up, the expression of these enzymes goes up, but in the presence of these protectants, the expression of these enzymes is substantially reduced. Some clinical evidence too exists where there's a comparison of the osmotically regulated preparations as compared to others. We can see the mean OSDI scores and the mean number of drops being lowered. We can see the switchover studies of a very large series of these patients, and they all reported improved comforts and improved clinical signs and symptoms with an improvement in tear breakup time significantly from baseline. There are other evidences again of these osmoprotectants becoming extremely useful. Here we can see patients who have dry eye have a substantially reduced amount of L-Carnitine levels in the tears of patients, and this opens up the possibility of therapeutic uses of these products. So here are some of the osmoprotectants that exist in nature. L-Carnitine, erythritol, glycerol, and trehalose are some of those that have been used now in ophthalmic preparations for dry eye. So to restore homeostasis, one has to protect against hyperosmolarity. There's an expanding pool of clinical data that suggests that there is a role of osmoprotectants. This osmoprotective effect depends on how much osmoprotectant the cell takes up and how long it is retained. So there are small osmoprotectants, which are smaller molecules, which leave and enter very quickly. And then there are larger ones, which require the amino acid transport for an active ingress and egress into the cells. So there's glycerol, which is very rapidly introduced and extruded. Erythritol, slightly larger molecule, which can passively diffuse in and diffuse out as well. And then L-Carnitine, which has to be actively transported. And it is the ideal combination of these osmoprotectants with different kinetics, which may work better to increase the overall protection in dry eye. So conventional therapies only help at the surface, whereas the osmoprotectants tend to neutralize the hypertonic state and increase the tear retention time and improve the osmoprotection that is possible. So in summary, dry eye produces significant ocular surface damage mediated by hyperosmolarity, which is a key mechanism in the evolution of dry eye, and cells utilize short and long-term regulatory mechanisms to maintain the osmotic balance. Hypotonic solutions provide only very transient relief. So compatible solutes, and if they are provided in these tier formulations that we have, help regulate the osmolar balance and reduce the stress and restore the homeostasis and the tear film osmolarity. So incorporating compatible solutes with different kinetic properties in artificial tear substitutes may be more effective in protecting our patients. So thank you so much for that patient listening.